And now for the expert panel, but first let me just tell you a little bit about the roundtables that we have planned later in the afternoon. We'll have 4 topics for roundtables, and I kind of sent out a survey, and some of the patients answered, and we've chosen based on that. The first is SJIA complications, MAS, lung disease, etc. The second is biologic usage. The third is steroids, growth, other side effects. And the fourth is pain, arthritis, and other movement problems in SJIA. So to repeat once again, the first is SJIA complications like MAS, lung disease, etc. The second is biologics usage. The third is usage of steroids, growth, and other side effects. And the fourth is pain, arthritis, and other movement problems. And we would suggest that if there's, for the parents, that they break up and go to different groups, that you learn more, and we'll also make sure that several people get an opportunity to learn from each group. But with that, let's go on to the next session, which is the expert panel. And for the questions for that, if the doctors can come up now, for the questions for that, what we'll do is that it's really basically a panel of questions. You get a chance to ask doctors what you've always wanted to ask, and we had some of that happen right after their talks, but this is your opportunity. And we've also gathered some questions from the online group. So what we'll try to do is to keep things moving along so that we give opportunity to several people to ask. So if you're asking a question, so we'll start off with the questions from this group directly. If you're asking a question, try not to have like 3 questions. So just let's make sure to give opportunity to lots of people. So with that, let's begin.
Before we get to the first question, there's a kind of a rule in pediatric rheumatologists that if you have 5 pediatric rheumatologists sitting at a table and you ask a single question about what to do, you'll get at least 5 different answers, perhaps more. So we'll approach this as different people get a chance to answer the same question.
So mine is Action Journal and just healthcare. So my son obviously sees multiple specialists, as I'm sure many of yours does. So what is one of the best ways to help get that communication between all of your specialists? Like, as you as doctors, what do you think is helpful? Because we often have specialists who, this one has this opinion and this one has this opinion, and they are differing opinions. And the best way to help communicate as a team of doctors rather than just these individual doctors taking care of him.
Yeah. So I think the gold standard is a care conference where you actually get the people physically together in the same space with you. And so you have a discussion focused on your child's problems and come up with a consensus about how you're going to move forward. So one doctor knows what his assignment is, another doctor knows what her assignment is, you know what your assignment is, and so you move together as a team. So that's, I think the ideal is to have such a care conference. The other, I think there's other ways you can get at it in the same way. You can have virtual conferences with FaceTime or WebEx, that sort of thing, if you have doctors in different institutions. And then if by chance your doctors and you utilize one of the patient portals like MyChart or that sort of thing, then that can be a mechanism whereby you can send questions to multiple physicians, and everybody can see the responses from other people. So you can use virtual substitutes for this sit-down face-to-face conference. But I think the CARE conference, you'll have to be the advocate for that, or you can get one of your pediatric rheumatologist or one of the nurses in the clinic to help organize that for you. But I think that face-to-face, there's no substitute for that, really. That's the best.
Just to be in line with what Dan said, I think we do in Cincinnati Children's, at least in our division, we do something called pre-visit planning to get to the point where we provide like the coordinated care and make sure that we capture all the different facets and all the different concerns of the various subspecialty providers. And actually, Dr. Morgan is heading that effort together with the nurses, so maybe she can say more about that.
Sure. So essentially just making sure we go through the chart and understand if there's different recommendations from different providers. If there's records that need to be obtained, make sure we have the records in hand, especially things that pertain like could be lab tests, could be other screenings, and then we make notes to there's a report that we give to our providers that indicates if something has happened between the visit or if there's been a new finding or a new recommendation. So sometimes we try and summarize that. The care team summarizes it for the providers. Another opportunity is for you to actually, if your different providers are not all in the same system, I would recommend collecting their business cards and bringing it to your visit and share it with your provider. Say, can you please make sure that X doctor gets a copy of the report? Most centers have electronic medical records now, and it's very easy to copy somebody or to make somebody part of a care team within the system. And that's a way to make sure that all of the letters get distributed to that provider.
I think the other thing is to have a very proactive primary care doctor. I did also primary care adult and pediatrics, and in the adult world, it's a constant problem with lots of just have to have a disease like systemic SJIA. So if you have a very proactive primary care doctor that can help coordinate everything, that can be helpful as well, especially if it's multiple centers.
I think a care conference is ideal, but just over the last 5 weeks, we've been trying to organize a care conference for one of my patients. It has been canceled again today for the 5th time, so it's difficult. I think in real life, a reasonable replacement for that would be email exchanges with all the critical people copied on those exchanges. But my bosses are telling me that I'm going to run in trouble with HIPAA regulations, and certainly becoming more and more difficult to do this kind of things from legal perspective.
Sort of a follow-up to that. What about collaboration in instances where the physician you may be seeing is not a part of the regular care team? For example, our rheumatologist at the University of Chicago will frequently refer us to an urgent care or ER just to have somebody else who's a physician take a look at our child and ask us to page them. And a lot of times these physicians won't do that, or they're very reluctant, and I don't know if it's an ego issue, because I feel like I've gotten that as well, or they just don't think that their person's opinion matters, but they're the one who referred us. How can we better encourage collaboration in that sense, because it's very frustrating?
So repeat your question again, please. So
Sure.
who's not collaborating with your pediatric rheumatologist?
Correct. Like if we've been sent to an urgent care, we live 3 hours from our rheumatologist. Yeah. So sometimes we'll call them, we'll page them with a problem. They say, get her in front of someone with an MD so they can look at her and page us, and we can talk doctor to each other and come up with a solution. And then we'll go to the urgent care, we'll go to the ER, we'll make that request, and they just won't do it.
Well, my suggestion would be to talk to the hospital administration and express your dissatisfaction, and that you have no problem posting that on a social website, and that probably will do the trick.
Okay.
So, but another answer to your question is what you're experiencing is the most important role for the primary care physician. So people end up working in urgent cares for a variety of reasons, and it's not because you're the most stellar physician at the top of your game, right? You're either in training and you're working moonlighting, or you've opted for a less kind of demanding role of your medical career if you're further along in your training. So urgent care physicians have a very limited perspective of what they're there for, right? The kinds of problems you're experiencing, I think, would be less intense if you had an excellent relationship with a primary care physician who would be willing to see you on short notice and would be the same person or the same group from one time to the next, so they develop some familiarity with your child rather than be a whole new experience every time you go to the urgent care or the ED. And a lot of urgent care physicians and ED physicians feel remarkably uncomfortable taking care of your children, and there's more they don't know about systemic JIA than they do know. So you're putting them in a very uncomfortable situation. So I think your child's care would be greatly enhanced if you had a strong relationship with a primary care provider of some sort. And if you don't have that, then perhaps it's time to look for a different primary care physician who will have that.
We have that with primary care. He's fantastic. We're talking about those cases where his office is closed, and urgent care is the only place we can go.
Well, the urgent care is always going to be a frustrating
mess.
place. Yeah.
Okay.
I have a suggestion too, is that perhaps you could ask your rheumatologist for just a letter, and it might get, dog-eared because you put it in your wallet or whatever, but that says, please, treat this patient who's got X diagnosis, these are some concerns, my pager number is, call me, for whatever. Yeah, then I'd go back to the administration thing, because when I'm on call, I know I get lots of pages from outside EDs. Yeah.
So it's interesting. This is a general topic of continuity of care, which I think we can all agree is really important when it comes to outcomes. We're in a unique situation where our daughter, since the age of 10, has been diagnosed. Now she's 19. So we're transitioning her to adult care. And I guess the question of the panel is, as we enter that, we're a little uncomfortable, let's say, with now that they're calling it a different disease, now they choose to call it Stills, even though the only thing that's changed is her age, right? So we're uncomfortable with the medical care, or at least the knowledge that's being presented back to us. I guess my question is, do you follow your patients? Do you continue to care for patients as they enter young adulthood for the purpose of continuity of care?
Yes.
How long?
Well, first thing, only because your daughter is now 19 doesn't mean that she has a different disease. She still has systemic JIA, and that is important also for treatment purposes. For instance, tocilizumab is approved for systemic JIA. And if she turns 19, she still has access to that drug because she still has systemic JIA. So what happens sometimes when you go to the adult side, they feel uncomfortable. It's easier for them to do prior authorization for medications if they have certain kind of diseases they're used to. So they sometimes change the nomenclature a little bit. And it's well possible that your daughter will be referred to as adult onset Still's disease for that. But from a scientific point of view, your daughter has still systemic JIA. Now, stepping back to the transition process, transition of care is a process, and what it requires is that the family and the patient is ready to advocate for themselves independently in another setting, and they can take several years. We have many patients with chronic diseases who stay with us until they are 25 or so, or even 26, and Dr. Lovell has some that are even older, because we don't feel that they're at the developmental point that they can be transferred, that the care can be transferred. In most cases, it can be transferred, but not for everybody is 19. I have a large number of patients who are 22, 23, and very often we keep them through the undergrad, college experience, and before they go, until they go to grad school, because it's very hard for them to get to the doctor. If they have a flare in college, they don't have a ride. It's hard for them to take off time and drive to a new rheumatologist, so we try to keep them here and are in close communication with them, because we know those patients over a long time. So if they have like a little arthritis or have a fever, we know what to recommend. And they have more trust in us than a new rheumatologist they may only have seen once or twice.
If I think about those patients who did well with transitions, those who started learning about the disease very early, the parents were encouraging them, in fact, to learn more and be more independent. Since the age of 14, they would come to see me, and the parents would be sitting quietly in the corner. They would let the kid to lead the conversation. So I think when you let them take control of the disease and of the issues and understand them well early, I think that is likely to make their transition better. So kids, since the age, I would say 13, 14, should take more active role during a visit with us. They should lead the discussion rather than the parents. And I think that sort of helps long-term tremendously.
There are structured transition guides as well that say, you know, expectations at different age groups of what can be done, and there's more of a movement to try and systematically implement transition programs through different practices across hospitals. I had showed a picture of that self-management handbook that parents helped us to revise. We just released that. There are stages by age, you know, what expectations are, how we should be at the visit, talking about, you know, at a certain age, insurance, you know, do you have your insurance card? Things like that to help to prepare people for the transition. I know yours was multifaceted because you wondered about the adult rheumatologist too, but a lot of it is sort of teaching our patients, our children as well, to be advocates and be aware for that transition too. Yeah.
So I have transitioned patients a number of times because I've done different things throughout my career, and all of these things are very important, but I found that the most important thing is just finding the right person to send them to. So when I left Rochester, New York to come here, I had to transition even pretty young kids to some adult providers. And if they're good adult providers, they're going to do their homework to be good for those kids as well, with some help. You know, they had my cell phone number and things like that. But so it may not be easy, but you'll find the right adult provider for her eventually, and all these other things are very important as well. Actually, what the adult providers have the most difficulty with is that they're not used to parents. So they're used to kids of parents, but they're not used to parents. And so that takes a little adjustment for them.
If I can just add to that question, you know, so I think many of us sitting here are not just members of the Systemic JIA Facebook group, but also of the Still's disease groups. And we kind of keep closely in connection with what's happening there. And I used to think when I was in the Systemic JIA group that this is a tough disease with tough drugs and et cetera, till I joined the Still's disease group. And I realized it's a tough disease with tough drugs and very little access to the drugs. Because somehow or the other, medicines are not approved, and often those patients just get dismissed as being, you know, needing painkillers. Why are you on so many painkillers? And it's a very different scenario. I was so thankful to be, my child is under the care of pediatric rheumatologists, you know, who at least have, you know, like we don't have problems with these things, the kind of problems they face. So it's less about, I mean, in my mind, it's not just about the child and young adult being able to take care of themselves. It's about the disconnect with the disease, between the two diseases, which we talked about, which is not there scientifically, but it is there in terms of the categorization. And all of us sitting here, all our kids are going to face that. And we don't have any answers as to how, you know,
so I think it's a little easier once they have the diagnosis, having done adult rheumatology as well. Still's disease in the adults, it doesn't happen very often. And just like in kids, it's a diagnosis of exclusion. And the older you get, the more things you have to exclude. So it becomes an even more difficult, and they're not necessarily, all of them, Alexei can probably speak to this better than me, but they're not necessarily all as sick as the kids get. So it presents a number of challenges, but since your child already has the diagnosis, I think as an adult, they'll not suffer the same as the ones that develop Still's as an adult.
I think at the time when transfer of care becomes an issue, the pediatric rheumatologist and the adult rheumatologist need to talk, and there needs to be the appropriate information delivered. What I advise my patient is to get the complete copy of the medical record. So let's say the young patient moves to another location, they still have the full medical record. And also there will be, and systemic JIA patients basically hand-delivered from a pediatric rheumatologist to an adult rheumatologist. And as a principle, they're probably are best served at a tertiary center rather than a freestanding adult rheumatology practice. Reason being is there are many more resources available at a medical center than in an individual rheumatology practice. So if lab tests are needed right away or x-ray, you don't need to go to 3 other places until the rheumatologist gets the answer.
I think advocacy, too, is really important. I know the Arthritis Foundation does a lot of that with advocacy for coverage of medication and continuing to go to Washington and let people know about these medications and how important it is for insurance to cover them.
Yeah, my comment is, I mean, your children have systemic JIA. They'll have systemic JIA when they're 8, 18, or 58, right? They don't change to adult onset stills. They had the onset when they were children. So they have systemic JIA, and they will continue to have that. When they go into an adult rheumatology practice, they may be labeled something else. But your child has systemic JIA, and that should remain the diagnosis. As was mentioned, access to biologics and other drugs is dramatically better for systemic JIA than it is for adult onset stills. They haven't got FDA approval for but I don't think they have any FDA approval for biologics. And so if your child gets labeled as adult onset stills, then that will automatically mean that the insurance company says no biologics are approved for this diagnosis. So you need to be, I think, an advocate to say, even though you're in an adult rheumatologist's office, my young adult patient, my 19-year-old patient, the disease she has is systemic JIA. And so don't let the lazy thinking or the lazy kind of process say, okay, well, we'll just call it this, because that's not accurate, and it has downstream consequences about access to biologics.
I would like to make another point. I've seen a couple of patients with systemic juvenile idiopathic arthritis who went into remission, did very, very well, and then many years later, when they became adults, they developed a flare, and it was just arthritis. And at that stage, they were diagnosed with rheumatoid arthritis. I think we need to be very, very careful here. We discussed the polycyclic course of systemic juvenile idiopathic arthritis. So in both of them, I think it was a second cycle of systemic JIA, and that disease still should be treated as systemic JIA. They were diagnosed with rheumatoid arthritis, and lots of time was wasted on methotrexate, TNF inhibiting agents, drugs that are not expected to work that well in that disease. So you may go into remission, and then the disease may come back as still systemic JIA later in life, and it should be treated as such.
That's where the parent comes in handy too. I had a patient like that once where the child pretty much forgot because it had been such a gap since the systemic and then coming back. And there it was like the parents, being involved in history was very helpful.
So I think somebody's already mentioned it, but it called to mind a patient who had polycystic or polyphasic disease, where once a year they'd have a flare up their disease and be fine in between. They had a very detailed letter from their physician, and there was a take-home message down at the bottom says, if you don't do this, then this can happen. And it was very definitive, detailed instructions of what the physician to do, what to order, what meds to give, and that sort of thing, based on, and the letter said, we've learned this through experience with this patient, making mistakes and having a patient get sick. We found this is the way it works. And the patient just carried the letter with him And when he would walk into the emergency room with his flare, then he just produced a letter so that he kind of, I think very quickly got the physician up to speed as to what's appropriate to do for the child. So the letter from the pediatric rheumatologist, for those of you who are seeking urgent care, I think is a very helpful thing to do. If you have the patient portal, like my chart, then you can also grant to the urgent care physician or the ED physician access to that portal so that that doctor in Birmingham, Alabama can get access, if they have the same system, they can get access to your child's records from wherever you are and actually look at the most recent lab results and the letters and that sort of thing. So patient portals do provide a way by which doctors all over the country can get access to results. And you're the one that own the access to the portal, and you can just share that with the treating physician in another institution so they can look at your child's records in real time.
This is particularly important for patients with macrophage activation syndrome. Those who had a history of MAS, it certainly may reoccur. The diagnosis should be established very promptly, and the proper evaluation should be started very, very promptly as well. So for those patients, it's very important to have a letter like that with explanation of what MAS is and what labs should be done if it's suspected.
I know we were talking about genetic testing a lot earlier and how usually when we have MAS, we were treated here at Cincinnati, thankfully, and we did genetic testing. And one of the things that did come back was the PRF1 mutation or gene, and it was just the one allele. But I wonder, I know we're not specifically looking at certain genes, but when we get that information, where do we go with that? What do we do with that? Is that just something that we know she's more prone to getting MAS and just leave it at that? Or just as a parent, do I dive into that more and figure out why and how and what would work best for her? Kind of.
I think the risk for recurrence of MAS in this patient population is higher. We cannot give you a number, but it is higher. Doesn't mean that it's going to come back, but certainly we need to be more careful, and you, of all these patients, you need to have a letter like that.
Okay.
We also notice that when we work with again, it's not your case perhaps, but when we start talking about procedures like bone marrow transplantation, that is a very important piece of information. We balance arguments against and for the procedure, and that's a very, very important part of that balance. So in your case, have you had several cases of MAS or just once?
Yeah, she's done okay so far, but last year she was flighted out twice, and the year before when we came here, we almost lost her. So she's had very aggressive episodes of it.
Well, to me, the letter that Dan was talking about, of all
right,
patients, you are the one who should have a very detailed letter explaining all these issues, and particularly the initial evaluation of suspected MAS.
I guess what I'm asking is, as a parent, knowing that information, now where do we go with treatment? And I don't know, I know we're kind of just grasping the beginnings of the genetic portion of what SJIA is and how it fits into everybody, but I don't hear a lot about it with other kids. I've maybe heard of one or two other ones. It's hard to find information on it too.
So knowing that there is a genetic mutation, that should prompt you when your child has a fever to reach out to the pediatric rheumatologist and the pediatrician early.
Right.
Because blood work, it doesn't mean that each fever is an MAS episode, but because you know there is a risk, you would reach out to a healthcare provider earlier, and that's how that information helps you at the current time.
Okay.
Now let's say there are more of those episodes, then going back to the pediatric rheumatologist and asking whether in that situation where there seems to be a more severe course, a bone marrow transplant would be warranted. That's another way it would basically pan out for treatment. And lastly, Although we do not have a cure for MAS or a foolproof treatment for MAS that works as a prophylactic as of now, maybe in a couple of years we do have it. And once that becomes available, then you would be, or your child would be one of the people who would get that medication first. And why would you, you would then know that your child had that mutation, let everybody know.
Okay.
I think what you're asking isn't known yet, but hopefully Dr. Grom in his lifetime will help us figure that out. Because I think you have good local support, at least so far it's been.
Yeah.
That I think she's well known. They're in a very remote place. I won't share, but
Yeah, they kind of listen to me.
The ER knows you well and is
Yeah,
on
they've
speed
seen
dial to Cincinnati, and it's so I think that you're getting the care that you need right at the moment. You just would like to know is something on the horizon that makes it less likely that she's going to get an MAS, and hopefully so.
So let me give you a dissenting opinion. The comments you got were specific to your polymorphism that your child has, right?
Yeah.
Okay, so I don't want other people in the audience to feel like if there's a polymorphism, then it's MAS and that sort of. That's specific information about your polymorphism. There's another way to look at it, which is every child has some genetic components that differ from either patient or either parent, excuse me. There's, what, Alexei, 10 to 15 unique polymorphisms for every child from either parent, okay? The vast majority of those times, those polymorphisms have no impact, no consequences, that sort of thing. So just to have a polymorphism by itself isn't necessarily negative or detrimental. It depends on the polymorphism. Many times you'd find polymorphisms and the meaning of that particular genetic variant isn't known. Most of the time, the impact of that particular polymorphism isn't known at the time you're given that information. So your question about what you do with this information, for you it's more direct and straightforward because your child's polymorphism has been studied. But many times you get polymorphisms that are shown up and the impact of them is not well known. Or it may be an impact that's completely separate from systemic JIA. So it doesn't, just to get genetic testing doesn't always lend you information that's helpful to you or your practitioner to understand about your child.
Okay.
Is that fair, Alexei?
Yes, fair. And the other thing I would like to stress is that we do genetic testing more and more. We find more variants that we've never seen before. We follow those patients. We create databases. There are quite a few publications right now describing the most common variants. So we'll learn about what each variant may mean long term. So it would be nice to, from time to time, to discuss this with the variant that you have with your physician, to see sort of, are there new publications on patients with this particular polymorphism? Are we learning that it's nothing, or are we learning that it's potentially pathogenic? So it's a work in progress, and certainly we will be much more informed about these variants a few years from now.
Thank you.
Just real quick, we know that Still's disease and SJIA are the same disease. Thanks for clarifying. But when you say that it's even more rare in adulthood, the Still's disease, does that tell us something about the disease, that as you get older that your immune system becomes more sophisticated in some way? I'm just wondering if you could speak to that.
Well, recently I've seen a couple of publications describing the incidence of systemic JIA and Still's disease over time. And if you look at that figure, so if you look, there is clearly the highest incidence somewhere around the age 1, 2, maybe 3 years. And then it kind of starts tapering off, and it sort of gradually keeps going down, and it sort of goes down all the way until 50, 70 years of age. So in terms of incidence, it's a very smooth curve. And clearly we see it more often in kids with, who are young and whose immune system is still developing. And then somehow, with the maturation of the immune system, I think the risk for this disease tends to go down. So there is, you're absolutely right, that there is something about the maturity of your immune system. And I think although Still's disease can be very, very severe, and again, the example of the movie that I saw yesterday, I think it's actually a very good example, by the way. It could be very bad. But with age, I think there is a trend to see less persistent, less severe disease. And again, I think it has something to do with the maturity of the immune system. Having said that, the treatment approaches, I think, should remain the same.
I have a question in regards to diet. I know I asked a question earlier about it. Is there any, we are early in the diagnosis. She was diagnosed in April, and of course I've read, my family has autoimmune diseases, so my sister has psoriasis. She does a lot of dietary stuff to help control her psoriasis. Has there been any studies? Is there any indication that diet at all plays a role?
It's unlikely that it's going to change the disease as far as we know. However, if your child is treated with steroids, for instance, it's important to try to maintain a healthy weight, and that can be furthered by using a healthy diet.
My concern is that if you decide, for example, to go ahead with a gluten-free diet, it will limit the number of products that you can buy in a supermarket and use in your cooking, right? And as a result, you may lose important sources of important vitamins, like, you know, you may avoid whole grain bread, right? It's a very important source of vitamin B1, B6, you know, name it. So when you start playing with diets, you may hopefully get some benefits, but you also put your patient, your child at risk to develop some other deficiencies for vitamins, for certain microelements. So to me, I think the diversity of food, fruits, vegetables, it's more important than a sort of particular diet.
Is it worthy to get checked for any of these deficiencies, for like vitamin D deficiency or any of those things?
Vitamin D deficiency we measure on a regular basis.
Okay.
Because it's important, you need vitamin D and calcium to strengthen the bones. And if persons who take steroids, they cannot effectively absorb calcium from the gut anymore. So you need to sometimes give extra so that there is enough calcium in the body. And calcium can only go in the bone if you have enough vitamin D. So your rheumatologist or your pediatric rheumatologist will be measuring both to make sure to optimize bone health.
Okay. Are there any other tests in terms of checking for vitamins or minerals or things like that that I should?
One thing I would avoid, because it will just drain your bank account and it won't really give you the information that you're looking for, is that there are these people that will do immunoglobulin testing to different foods. They're actually IgG proteins, sort of like what I showed you. There's E, that's related to allergy, and G, it's related to your immune system. So it's amazing that we can eat anything, because we should be allergic to everything that it's all foreign to us. So we will make these IgG proteins to just about anything that we eat. And there are people making a lot of money, not very many, but some, to say, oh my God, the IgG level to X and such is very high. It's probably because that's what your child eats a lot. So I think that someday some of the information you're looking for might be available, because people are looking at your genetics coupled with what types of organisms live with you, because as adults we have like 2 pounds of microorganisms that live with us. So someday it will be, you have this genetic makeup and you have these microbiome cohort, therefore you should eat this diet. But we don't have that kind of information at the moment. So I would agree with Alexei, you can end up then eliminating a lot of things that could be beneficial. Someday, maybe that kind of data will exist. That might be part of the environment piece that leads to these diseases, but we don't have that information yet.
I just want to add, this comes up, oh, sorry, go ahead. I would say this comes up all the time. You know, this is what we do all day long. We eat, right? So how can we control it? And it's a question that everyone has. And unfortunately, those studies are just really, really hard to perform, which is why we don't know more about it, because I think it is a question everyone has. There's some general advice like avoid high fructose corn syrup. I mean, stuff like that, the general good health things, try and reduce your sugar and refined sugars and stuff like that. But unfortunately, we don't have other evidence beyond general health. Try and be more plant-based, but your kids need protein. So you got to be careful. But it's more that general advice rather than specific to autoimmune conditions.
Just one more. It was only in the late 1990s that we were able to map the human genome. So progress is being made. It just takes time. So, to do these genetic tests, we didn't have an ability to even do that until the last 15 years or so. So stay tuned. But yeah.
Yeah, just to follow up on the comment that Dr. Huggins made about we all have 2 to 3 pounds of bacteria and yeast and fungi that live alongside us, actually in the wall of our GI tract. That's about 1,500. Most of us have, and your children included, have 1,500 different species of microorganisms that live along the lining of your GI tract. And those microorganisms interact with the immune cells line of the GI tract to alter your immune system. And we're just now beginning to look at that in general in humans, and there's been a very few, very small early studies of that in children with JIA. So I think it may be that there is an important interaction between food and the bacteria and the yeast and the antibiotics and how it alters that mix of bacteria, but we just don't understand that yet. But the claims about a particular diet doing this, a particular diet doing that, really I think are very poorly supported by reliable scientific literature. And the comment about vitamin D and calcium is not related to causation of the disease or why your child got systemic J, but really looking to assess the impact of the chronic inflammatory state on your child's ability to absorb vitamin D and calcium, that sort of thing. So this is a consequence of having systemic J or the medicines you use rather than vitamin D deficiency or excess causing systemic J. So.
I got a question about biologics. So when, say your child's on a biologic and the symptoms seem to be in remission, everything's going good, when do you start weaning off those biologics? And if you do, if and when you do, are there any prophylactic things that can be used to prevent a flare in the future?
Well, so I think you need to look at the child's status very thoroughly when you start to make that kind of decision. So it's more than just the absence of symptoms, but it's a normal joint exam, or at least a joint exam that doesn't support evidence of active disease. It's normal laboratory measures of inflammation. Dr. Grom talked about some additional laboratory tests that could be informative, like IL-18. In our clinic, we're investigating the role of ultrasound evaluation of the joints, because we know that about 20% of the time when we, with our fingers, say a joint exam is normal, you can find subtle changes in the joint with ultrasound. And we don't have the scientific data yet to say, okay, those findings uniformly predict an increased risk for flare. They do in adults with rheumatoid arthritis. So if you have ultrasound evidence of subclinical synovitis, then your risk for flare of the disease or worsening of the disease if you stop the medication is, in some studies, 10 to 15 times greater. So I would suggest when you're thinking about that decision that you evaluate your child as thoroughly as you can to make sure that in all ways you look at the disease, there's no evidence of disease activity. And then if you decide to stop the biologic, you keep all other therapies stable so that you only alter one medicine at a time, so it's not confusing what might have attributed to the flare if you've changed 2 medicines at one time. So everything else other than the medicine you're stopping needs to stay exactly the same, okay? And then you can more accurately determine if they get worse or get better, whether it was due to that change you made. And then you need to be prepared to restart the medication with mild manifestations of the disease. You really don't wait to where things get more quite obvious or active joints. You know, we talk to families and say, okay, if the morning stiffness comes back on a consistent basis, or they start to develop pain with activities that didn't used to be painful, then that's enough to pull the trigger and restart the medication, rather than wait till you actually get a swollen joint, and then it may take longer to get back under control.
I think when it comes to systemic JIA, the only piece of guidance that we could use perhaps is the extension part of the trial of tocilizumab in systemic juvenile idiopathic arthritis. If I remember correctly, you should know the data better. About 40 patients in that trial stayed on the drug in remission for about a couple of years, and then the decision was made to start tapering the treatment. Remember, tocilizumab is administered every 2 weeks, so the first step was to switch to every 3 weeks, then every 4, every 5, and then stop, correct? Well, you know the results better.
Yeah, so the background medications were then also tapered off. And among, I think there were close to 180 patients entered the trial. 40 patients were in the state that they had like quiescent disease for at least 6 months. And yeah, no, not 3 years. So anyhow, so they were in quiescent disease for a very, very long time, and then it was slowly basically tapered off over almost a 2-year period. And among those, only, I think like 13 of them remained in remission.
Right. Now there's some clues you can get about whether your child is appropriate. For example, if your child goes on a week, you go on vacation, you forget the medication, right? Then that's that period of time where they didn't get the medication. How did they do? Or they get an intercurrent infection or a surgery or something like that, where by medical instruction you're told not to give them the medication. How did they do? With anakinra, its half-life is extremely short. So even missing a day or two, or Kineret, even a day or two of the medication, you can see consequences of that if your child truly does need daily Kineret. We have some patients on Kineret every other day, some patients every 3rd day, so not everybody needs it every day, but the only way they found that out was kind of trial and error. But so the first step would be, I think, just to hold the medication for a day or two if it's a short half-life medication. Things like Actimra and canakinumab are medications that have long half-lives in the body, and their biologic effect is even longer. So stopping those kinds of medications, you may not see the impact of that change for the child to get worse until 2, 4, 6 months later. So it can have a prolonged beneficial effect way past the time you're giving the medication. So you need to give enough time to assess the child to see if the biologic effect is truly wearing off, and that can be 2 to 4, 6 months with Ilaris and Actimra.
Maybe along the line, you know, there is not like you are on a medication, then you stop it, but it's very often done that the dose is not increased although the child is growing, or you give, if it, in the case of tocilizumab or, you know, Actimra, that you stretch the intervals. And that was actually done in the clinical trial, that you give it every 3 weeks. If things go well, you give it every 4 weeks. And then, you know, you can decrease the dose, and by that, slowly decrease the amount of medication. And if the child gets worse at any point, you know that you need to go back to the previous step.
I'm going to throw a monkey wrench into everything, and you guys can call me a hippie, tree hugger, or whatever you want to say. But I asked Dr. Grom yesterday, but what is your guys' opinion about CBD oil and on inflammation and like just things of that nature. Because like I told Dr. Grom, I'm not Dr. Google or anybody like that. I just heard that, you know, the CBD oil does help with inflammation and things of that nature. So things that I looked up on the National Institute of Health, I can't understand any of that stuff, but I read it anyway. And the gist I got from it is that it might help, but I'm not a doctor. That's why I'm asking. So, and like I said, I had to throw the monkey wrench in there.
Yeah.
Call me what you want. It's okay.
There's lots of things in medicine we do not understand. I do not think that it's harmful. There is no evidence. It's probably one of these poorly unsaturated oils. That's my guess. I'm not familiar with it. You know, from the name, I could look it up too. But my best guess would that it's not harmful. So you can, you know, use it. But first, do no harm. But I would discourage you to use like alfalfa sprout or something like drops that activate the immune system, because that may do harm. But just let us know what you're giving, because let's say that oil causes diarrhea and we scratch our head. Why the hell is, you know, what did we do with our medication that now causes diarrhea? Then that piece of information we really would like to know.
Yeah, I agree with that. And pediatric rheumatologists in general are very dedicated to the collaboration with you on the care of your child. So I haven't met one that I think would be a physician which you should think about hiding the information because they may react so negatively to it that it would taint the relationship. So you really need to be forthcoming, because if anything that you give your child has a potential to have a benefit, it also has a potential to have side effects. And as Dr. Bruner talked about, if your child has some side effect from a supplement, and we don't know they're taking the supplement, then we will be thinking about changing the treatment or figuring out a treatment for the side effect. If it's diarrhea, then we may be prescribing anti-diarrheal agents. In fact, what needs to be done is to eliminate the supplement that was causing the diarrhea. So I think you need to really engage with the physician as a partner in this process so that everybody knows what's happening. And we all know that whenever they've looked at it, around half of the families utilize supplements in some way to help improve the outcome of their child. So it's a common thing for families to do. So it's not a surprise to us that families are trying these things, and it's really very important to be open and sharing so everybody's on the same page about what's going in your child or on your child, either way.
Known side effects for CBD? Do you happen to know?
The only thing I could come up with, if you take that oil with the other oral medication together, it may change absorption.
Okay. Is anybody using it with their kid? Just like, no, not yet? Okay. Yeah, I'm curious about it as well.
So this is kind of a random, very narrow question, but just because someone brought up the prophylactic treatment when they come off the drug, has there been any testing? I know several people that use low-dose doxycycline for certain inflammatory stuff. As far as at low doses, it'll do like interleukin 6, interleukin 8, tumor necrosis factor. Has there been any testing with low-dose doxycycline and actually prophylactic measures?
You know, I could give you, what comes through my mind is, you know, you probably get your low-dose doxycycline by eating the regular chicken from the grocery store. So there is no use to even sprinkle anything else on top.
Fair enough.
So let me, actually, the doxycycline and minocycline stimulate a whole school of learning we had not too many years ago, right? There have been advocates for the doxycycline and minocycline are in the tetracycline family of drugs. So probably for 40 years, there's been a cohort of adult patients with rheumatoid arthritis who are convinced that's the treatment of choice for rheumatoid arthritis. And some of them advocated very strongly with their senators, such that about 15 years ago, it went into the funding for the NIH that required them to do a study of a tetracycline for rheumatoid arthritis. And so against all their judgment, they were required by law because it was part of their authorization. So they did a trial of was it doxycycline they did in the RA? They did a trial of doxycycline in RA patients. And what they found, quite to their surprise, was there's a moderate anti-inflammatory effect. But also about 20% of that population developed autoantibodies. So again, it's an example of any agent that's able to exert a benefit can have unexpected adverse events too. So 20% of these RA patients became anti-nuclear antibody positive, right? And we see patients sometimes 1 or 2 a month that are put on doxycycline, minocycline by their pediatrician for their acne, and they come to us with autoimmune type problems. Arthritis, muscle pain, muscle inflammation, rashes, and they've also got an ANA. So the medicine that was given to them in relatively low doses for their acne has caused this autoimmune disease. And your child already has an immune system that's not regulated well. I don't know that I would advocate giving a medicine which can alter the immune response. And what they found out from that trial was that antibiotics do have immunologic regulatory aspects sometimes, and it's now been found in a variety of different antibiotics that they have immune regulation things over and above what they do to kill off bacteria and viruses. So that trial stimulated this whole school of learning about how the wider impact of antibiotics in people's body. So I would be very reluctant to use low-dose tetracycline of any kind in a patient who already has an immune system that's dysregulated. Because we see previously healthy patients get put on these medications for acne, and they come into us with immune problems.
And you can't use those medicines under the age of 8 because it affects the growing skeleton. So.
Okay, great. Thank you so much.